Dear friends, good afternoon. I would like to thank the committee for inviting me to participate in this interesting congress. And however, due to these circumstances that this global thing around the world, we're not able to travel. And I strongly apologize. Please accept my apologies. I will be deprived from this warm hospitality in Cairo, but I'm looking forward to be with you in the next meeting. So the topic is, where are we today regarding fertility and pregnancy in thalassemia? These are the data that we have published some years ago about the fertility in Cypriot women with thalassemia. You can see we have a significant number of women who became pregnant and delivered healthy children. However, what is interesting here is that a number of women had hypogonadism, either manifested as primary amenorrhea or secondary amenorrhea. And these women were able to conceive following proper treatment. This, of course, indicates that ovarian function is well preserved in women with thalassemia, despite the fact that they develop hypogonadism at some time in their life. Following this publication, a number of other reports reported in the literature from London, from Turkey, from Greece, from the UK, from Italy, and all the papers agree that with proper care and guidance, pregnancies among women with thalassemia, they are practical and result in successful outcome. No significant complications regarding the heart function, and some reports they stated that there is an incidence of preterm labor and intrauterine growth retardation, and that the incidence was higher compared to the background population. Pregnancy is possible, safe, and usually has a favorable outcome, provided that a multidisciplinary team is available to take care of the thalassemic pregnant woman. And most importantly, fertility is well retrieved in women who have hypogonadism. Pregnancy, therefore, is feasible, safe in women with thalassemia, provided they have started pregnancy with a normal resting cardiac performance and optimized iron overload. The care of this woman has to be provided in specialized centers under a multidisciplinary team. Everybody emphasizes the importance of the multidisciplinary team to take care of this woman. And when we say multidisciplinary team, we mean the cooperation of the hematologist, the endocrinologist, the gynecologist, the cardiologist, the internist, and of course, we need the help, the important help of the nurse, the nutritionist, and the psychologist. Looking at the literature and regarding the outcome of pregnancies, close to 500, most of them resulted in full-term babies. The incidence of preterm babies slightly higher than the general populations. Regarding now the abortions and the stillbirth is compared to the general population. Most of them were singleton, 2 in 24, and we have 2 cases of triple pregnancies. Regarding the ferritin level, it is expected because of the fact that the chelation therapy usually is discontinued during pregnancy. The ferritin level increases before and after pregnancy. Now, in cases where the ferritin level increases remarkably during the last trimester of pregnancy, Sometimes the placenta functions as a chelating agent. Then during this phase, the end of the second trimester, chelators can be safely given. Now, regarding now the function of the heart, we examined before pregnancy, at the first, second, and third trimester, and of course after labor, 35 women, and no significant cardiac complications were observed. There was a mild diastolic dysfunction during the third trimester, and this corresponding to the physiology of the heart function during this late stage of pregnancy. And therefore, the result, the summary, the conclusion is that pregnancy is safe regarding the cardiac function, provided, however, and this is important, that pregnancies, they have started early on proper treatment and have a normal resting cardiac performance. Therefore, to summarize all data that they have published in the literature, pregnancies among women with thalassemia, they are feasible, they are safe, and they have a successful outcome. No severe complications, obstetric complications, no deleterious effect of pregnancy on the course of thalassemia. Spontaneous fertility can occur in well-chelated and transfused patients, women with primary or secondary amenorrhea. These are the clinical manifestations of hypogonadism. They well preserve their ovarian function, and therefore they are able to conceive following closely monitored induction of ovulation. Normal resting cardiac performance and optimized iron overload, they are vital requirements before pregnancy. There is a minimal risk of preterm labor and growth restriction, and emphasizing again that the medical care of this woman has to be provided by a multidisciplinary team working together. We have happy families. That was a case many years ago. This lovely lady started pregnancy with not the best of iron and cardiac function. This pregnancy was tripled. She developed a lot of problems, but luckily she recovered and she was able to deliver these 3 lovely children here. We have issues, therefore, regarding the medical history. In some cases, pregnancy is not recommended in women who have a poor cardiac function and they are severely iron overloaded. Emotional dilemmas often pose some problems. Legal issues have to be addressed. And of course, we have ethical issues that we have to face and discuss with the patients. There is increased risk of obstetric and perinatal complications, at least from the report from Italy, 2017. And some problems that could influence maternal outcome and obstetric outcome includes anemia, iron overload, cardiac dysfunction, thromboembolism, alloimmunization, infections, and endocrine and bone disorders. So all these medical conditions, they have to be addressed and explored before when in a woman who is seeking pregnancy. There are some unanswered questions, though, regarding the safety for the baby when iron chelation therapy has to be provided, and if there are any potential effect of pregnancy on long-term maternal health outcome, especially when maternal complications occur. From the experience that we have from all these years here, no significant detrimental effect of pregnancy on the long-term maternal health have been reported. And therefore, pregnancy is considered as a safe and natural condition in a woman with thalassemia. Now, who is eligible to become pregnant? Normal cardiac function, normal liver function test, ultrasound is needed, checking the vessels, the clotting factors of the Doppler, establishing normal thyroid function and normal parathyroid function as well, glucose tolerance test to see the pancreatic function, check for viral infections, HPV, HIV, iron status, and the assessment of a woman when she seeks pregnancy is to optimize chelation therapy. Pregnancy has to start with a normal, close to normal ferritin level, normal cardiac and liver function, normal thyroid function, check for viral infections, optimize diabetic control if the woman has diabetes, and closely monitor the pancreatic function during pregnancy, review the medications that she is receiving, screen for acquired red cell antibodies, because here we have the risk of hemolytic disease, check the partner for hemoglobinopathy, and if necessary, arrange genetic counseling. Emphasize folic acid supplementations during pregnancy, stop desferrioxamine and vitamin C, stop ACE inhibitors. The woman can continue metformin safely, but there are some cases that we need to change the anti-diabetic medication from oral hypoglycemic drugs to insulin, stop biphosphonates, and ideally stop biphosphonates at least 6 months before seeking pregnancy. And like we give in every pregnancy, give calcium and vitamin D. During pregnancy, maintenance of the hemoglobin level around 10, and this allows normal growth of the baby. Frequent low volume blood transfusions, therefore, are required. Serial ultrasound to monitor the growth of the baby, regular cardiac monitoring, assessment of endocrine function, assessment of thyroid function periodically, and of course, arrange for oral glucose tolerance tests to evaluate pancreatic function and establish normal glucose homeostasis. Emphasizing again that this has to be achieved by a multidisciplinary approach by all specialists involved in the medical care of women with thalassemia. Any risks have been reported. Women with non-transfusion dependent thalassemia, and these are women who have never been transfused or have received minimal transfusion, they are at risk of severe alloimmune anemia if transfusion is required during pregnancy. And pregnancy increases the risk of thrombosis. Having in mind that thalassemia is also a state, hypercoagulable state, therefore we need to keep these women who are at higher risk, and these are women who are not regularly transfused on prophylaxis treatment during pregnancy and the period postpartum. The key point, therefore, is that the desire of thalassemic women to achieve motherhood should be recognized, respected, and approached with special caution and sensitivity. Issues that have to be addressed include the medical issues, legal issues, and ethical issues as well. And these issues, they have to be addressed prudently in order to optimize the patient's quality of life, ensuring the best outcome for the mother and the baby, and of course, having in mind that we should balance between the quality of life of the woman and of course, the safety of her life. Any risk during induction of ovulation? The indication for inducing ovulation is, of course, hypogonadism, primary amenorrhea, secondary amenorrhea, oligomenorrhea. Women with a normal menstrual function who fail to conceive, or when both partners are thalassemics and the pregnancy is planned. And of course, the risk is the twin or triplet pregnancy, but these have to be prevented with a proper gynecological treatment. And another risk is the ovarian hyperstimulation syndrome. What's this syndrome? It is a syndrome that is manifested with excessive weight gain, severe nausea and vomiting, severe abdominal swelling, difficulty in breathing, blood clotting, decreased urination, kidney failure, and severe abdominal pain. And this is the result of ovarian hyperstimulation syndrome because of the huge amount of estradiol that is produced by the follicles that they are stimulated. Therefore, we need to monitor the ovaries on a regular basis, measuring the levels of estradiol and performing ultrasound to reduce the risk of ovarian hyperstimulation syndrome. We have tissue edema that results in ascites. We have hypovolemia resulting in liver and renal impairment. And of course, we have thromboembolic events. And these are all results of the release of the vasoactive factors that cause all these complications. And what is the treatment in this case? First of all, we adjust the fertility medications. Often the woman needs to be hospitalized in the intensive care unit and be given intravenous fluids. Of course, the procedure has to be stopped. Therefore, the embryos have to be freezed and delayed the transfer. If ascites is so severe, then paracentesis is a therapeutic approach. And of course, medicines to ease the symptoms and reduce the activity of the ovaries, and these are the aromatase inhibitors. In order to understand the procedure of this syndrome, and of course appraise some markers that we use when we measure the ovarian, when we calculate the ovarian reserve, it is essential to know some physiology of the folliculogenesis, which is the growth of the follicle. The follicle starts from the early stage of the primordial follicle, then it grows to become the primary follicle, the secondary follicle, and then when antrum is developed, it descends the antral, the early antral follicle, and then when it grows more, the follicle becomes the pre-ovulatory or the Graafian follicle. Now, during this stage, the growth of the follicle does not depend on the gonadotrophins. Therefore, the woman who has hypogonadism, she is able to achieve the growth of the follicle up to the secondary stage. And then afterwards, there is a need of exogenous FSH for the growth, for the follicle to grow. Now, when we measure now the ovarian reserve, which by definition is the capacity of the ovary to provide eggs that are capable of fertilization, and of course, resulting in a healthy and successful pregnancy. If we see the ovarian reserve over the years, we see that there is a decline. And the maximum ovarian reserve is around the age, between the age of 20 and 30. And of course, we have some markers that we calculate the ovarian reserve. And this is based on measurements that we use to evaluate the size of the residual ovarian follicle pool. Low ovarian reserve is considered predictive for low chances for spontaneous pregnancy and for poor ovarian response to when hormones are given for stimulation. At birth, the woman has close to 1 to 2 million of eggs. These are decreased in puberty, and of course in menopause, the woman is depleted from the eggs. One marker that we use is the antral follicular count. As we saw before, the follicle grows from the primordial follicle to the primary follicles. Women are born with the primary follicle, 1 million primary follicles in their ovaries. And the antral follicle can be visualized with ultrasound. It declines with age, and this reflects the pool of the primordial follicles. Reproductive aging is directly related to the decline in the pool of these follicles. And this is how they are visualized in ultrasound. They decrease with age. Another marker is the anti-Mullerian hormone. This is produced by the pre-antral and early antral follicles. It is the earliest marker of the change with age, and the job of this anti-Mullerian hormone is to prevent the recruitment of the non-dominant follicle, therefore reducing the responsiveness of the ovarian follicles to the FSH during follicle recruitment in the cycle. It is a marker of ovarian reserve. It declines with age. And now coming back to thalassemia, women with thalassemia, they have a low antral follicular count to begin with. And this, of course, declines with age. They have a low AMH level, and this declines with age. If you compare this with the normal population, normal AMH levels range between 0.7 to 3.5 nanograms per ml. Low ovarian reserve is indicated when the AMH level is lower than 0.7. AMH level is directly related to the ferritin level, and therefore it is important for the woman who seeks thalassemia or who seeks pregnancy, or any other woman who wishes to become pregnant, to have a normal iron level. And the take-home message is that improved fertility with optimized iron overload. The desire of the woman has to be respected. The life expectancy is improved. The quality of life in women with thalassemia is improved as well. And of course, this increases her desire to become a mother. During the preconceptual phase, careful management to establish normal cardiac function and normal iron load. And of course, this woman with thalassemia who seeks pregnancy has to be approached by this multidisciplinary team. Now, how about the fathers? The picture is more or less the same. We have 4 cases of fathers with hypogonadism that they became fathers following proper treatment. The number of children, of course, has increased. We can induce spermatogenesis in males with hypogonadism or in males with partial hypogonadism or arrested puberty and low sperm count. And this is a protocol that everybody follows: baseline testosterone and semen analysis, administration of human chorionic gonadotrophins, monitoring the testosterone level to adjust the dose, and then we continue with combining human chorionic gonadotrophin with recombinant FSH, and this treatment is given over a year. If azoospermia persists after a year of treatment, then of course we have to stop the treatment. Some patients respond nicely and some patients do not. And of course, this depends on the age when the treatment was initiated and the iron status. The earlier the treatment begins, the better outcome is for the male. Remember that 1 sperm is sufficient for assisted reproductive technology procedure, that this is obtained from ejaculated or spermatozoa that have been cryopreserved. In some cases, testicular spermatozoa, they are retrieved by testicular biopsy. Of course, this is a painful procedure and not everybody likes this. And of course, the question remains whether there is any damage of the DNA in males with thalassemia, because there were some reports that there is increased fragmentation of the DNA in the sperm of thalassemia. Two reports, but these go back 20 years back in the literature, reporting that there is increased in sperm DNA damage, negative correlation between the sperm motility and the DNA damage, suggesting that iron overload predisposes sperm to oxidative injury. And of course, this finding has important implications in assisted reproductive technology procedure. However, from the experience that we have from all these years, 30 years of experience here, we haven't addressed any important issue regarding the offsprings of the fathers with thalassemia. Another report from our friend DeSantis, that he's a pioneer in endocrine publications in thalassemia, respect to the Vincenzo. Patients with thalassemia with low sperm concentrations were more likely to have a higher degree of defective chromatin package, and suggesting that there is a possible detrimental effect on spermatogenesis from the iron chelator desferrioxamine. So we have iron overload on the one hand, and then we have the detrimental effect of desferrioxamine on the other hand. So these patients, or like all thalassemic patients, they have to be well controlled and be given the proper treatment so that we don't face the detrimental effects of iron overload and the side effects of the chelating agent. Again, indicating that normalization of total iron, body iron, with very intensive combined chelation reserve cardiac and endocrine function in thalassemia. Again, an old report from our friend Farmaki from Greece. 7 out of 14 patients, hypogonadal patients receiving testosterone therapy, they stopped treatment, and 1 male became a father following this intensive combined chelation therapy, and 6 out of 19 females who were hypogonadal, they were able to conceive. So this is another take-home message. Now, what is the recommendation? Women with thalassemia wishing pregnancy, if the partner is non-heterozygote and the woman has normal menstrual function, usually this results in spontaneous pregnancy. However, when the woman has amenorrhea, or when she's not able to conceive, then we have to proceed to assisted reproduction technology. If the partner is heterozygote, then one option is the pre-plantation procedure. However, another procedure when the partner is homozygote is either adoption or a gamete donor, either sperm or ovary. However, in some cases, when the partner is homozygote, we have to show respect when they wish to have their own child. And this is a couple, both of them thalassemics. Their small boy grew up, he's a student now. But unfortunately, we have lost this beautiful woman following complications of COVID last year. So I would like to thank you, all of you. Hope to see you soon in Cairo, and sending my best wishes. My thanks again for inviting me, and See you soon in Cairo.